When it comes to discussing our bodies, we often get a little uncomfortable. Women's health issues are often seen as off limits, taboo topics we just don't talk about. It's time for that to change. Let's talk. Welcome to the Brave Mama podcast, where we are going to do exactly that. Discuss everything from periods to pregnancy, motherhood to menopause. No topic is off limits. Join Stephanie Thompson, the Brave Mama and author of The Day My Vagina Broke, as she asks other brave women about their personal health challenges and triumphs. You will learn, laugh and cry as Stephanie finds out everything you wanted to know but were too afraid or embarrassed to ask. So, grab a cuppa and enjoy.
Hello and welcome to another episode of The Lowdown with Brave Mama. I am your host, Steph Thompson. Today we are sitting down with Dr. Elizabeth Skinner, who is a midwife, a mum, and a researcher. She interviewed over 40 women and men, which were the catalyst for the creation of the Australasian Birth Trauma Association. Liz's vision for better health literacy is so inspiring for women right now, but also to our future women. Today I've grabbed a cup of Madame Flavour's English brekkie. It's just been always a go-to favourite of mine because I can drink it all day long, just as much as I could sit and listen to Liz talk about women's health all day long. And as we are getting closer to the end of season 1, there are 4 episodes left after this one. We would love for your feedback. We need to know what you want in season 2. We've got some ideas. We've already got some people, amazing women lined up. But if you let us know who you think you'd like to hear from, send us a message on Instagram at Brave Mama, a direct message, or you can send an email at stephanie@bravemama.com. Hi, Liz. It's so lovely to have you on the show today. Thank you for coming on and chatting with us.
Hi, Steph. It's great to be here and work with you and hear all your great questions. Hope I can help.
I think you will. Actually, I know you will. So let's kick off. So tell us, Liz, who was Elizabeth Skinner? Sorry, Dr. Elizabeth Skinner, I'd like to add, before becoming a mum?
Before becoming a mum, she was an intensive care nurse who worked in Melbourne, St Vincent's, London, ICU, and Sydney with Victor Chang.
Oh, wow.
So she was working in trauma, cardiothoracic intensive care, and that was the life that she ended up thinking she would have.
Yeah, wow. Victor Chang, that's amazing.
Yeah, he was a great inspiration to me, a great man. His whole team, in fact, really impacted on me and showed me that you could change things and you could always think outside the square. And I think my research and working with women has been heavily impacted by Victor Chang, and it's very sad that we've lost him.
Yes.
And all his innovative methods. So I think that I was very blessed in the fact that I was able to work with not only Victor, because in London I worked with another team that was equally as good, yes, and in Melbourne, St Vincent's. So, innovation.
That's brilliant. What a legacy. That's so good. So when obviously you are a mum, would you mind sharing with us what your birthing experiences were like?
Okay, I have 2 beautiful boys. My first delivery was awful. It was a traumatic delivery. Mm-hmm. After I worked in cardiothoracic, I ended up working in maternity and doing my midwifery certificate because my mother got very sick, and I ended up doing that in Sydney. It wasn't particularly the direction I wanted to take in my life, but I saw a lot of really terrible deliveries.
Okay.
And at that point, just to answer a bit of your last question, I probably didn't add to, I really thought way back then that I wanted to change things.
Yeah.
having worked with a great team like Victor Chang. So then when I went to have a baby myself, I didn't expect everything to go completely wrong, and it did.
Okay. Of course. I mean, yeah.
It went terribly wrong.
Okay.
I think I wasn't working in maternity at the time. I was teaching nurses, which is another passion of mine, and which is what I'm doing now. And I had high ideals of the birthing process. I decided to go to a birth centre in a major Sydney hospital that had a neonatal intensive care, but the birthing centre was not to be. There was a lot of a lot of issues. My baby was too large.
Okay.
And I ended up in labour ward, and we nearly lost our first son, and I got severe birth injuries.
Right. And so your plan or your ideal birth was obviously to have a vaginal birth at the birthing centre. And when things didn't happen, so then you went to, did they have to transport you to the hospital while you were in labour?
No, it was in the same hospital. It was in a big major hospital in Sydney.
Okay.
They just transported me to the labour ward, but it was the walk of shame because even then, if you didn't make it in, the labour ward staff didn't like the birth centre staff. And the birth centre staff were very suspicious of the labour ward. So I was sort of the jam in the sandwich, and I ended up in the labour ward. Having seen some pretty terrible deliveries, I thought, this is it. I'm going to be one of those statistics.
Yeah. Wow.
And I was worried about that. But yes, and that's exactly what happened. The day was very busy. The labour ward was unable to send mothers to have caesarean sections. If I had known straight away, I would have, I was having this huge baby. I was a private patient.
Yes.
I would have asked for a caesarean section.
Wow. Yeah.
And my life would have been completely different.
So that, I mean, hearing that, and obviously you had birthed your son prior to me in 2015, to know that that has happened historically, I mean, to know that this type of birthing injuries and birth trauma happened when I gave birth was new to me. I never knew that this happened. And then now,
yes, that's right. I think as women, we have high ideals, and somehow I tend to think there's a little bit too much emphasis on the natural birthing method, and that all women deliver differently.
Yes, and to know that it's actually been happening for generations is a little bit alarming, isn't it? Really?
Well, it's this was a great interest of mine. It's good that you're bringing it up. When I was doing my PhD, I looked into the history of this, and yes, the stories were hideous. But once again, women are very, very brave, and hundreds of years ago, it's hard to often get transcripts. But yes, I got some. Yeah, the women who suffered in silence was the common problem, and I think that's where you're coming from, Steph.
Yeah, I do. Absolutely. Was, just out of curiosity, was your second birth? I don't want to say better. But was it a different experience for you?
No, it was much better. I miraculously, I think I definitely had some distress after having Alex, because we nearly lost him. I delayed having any more babies, but 4 years later, I had a vaginal delivery, and but I had prolapses
in between,
and the doctor was very, very gentle and very kind. This time it was a different hospital.
Okay.
There weren't as much politics. It was an outer city hospital, not an inner city hospital. And a midwife was there and was very gentle, and
wonderful.
It was a completely different experience. Yeah.
Yeah, I think a lot of the women I've spoken to who have had birth trauma during their first experience, and be it, obstetrician or midwife and vaginal birth or Caesar, it doesn't particularly matter. But a lot of the women who were brave enough to have a second birth, a second child, did find that process quite cathartic because it was very different to the first. I don't know. Well, I haven't
Yes, I
spoken
agree.
yeah.
No, I interviewed women that said exactly the same. You're correct.
Yeah.
And for me personally, yes, that was unknowingly. I wanted another baby despite having prolapses. But yes, it was a healing experience. I mean, a lot of women after having traumatic births want to have Caesars, and that's fine too.
Yeah.
But I don't think I really, I don't know, I didn't even think of that. And I had very supportive midwives and very supportive doctors. So,
Wonderful.
It was good.
Yeah. And, a lot of questions I get asked, it's probably one of the most frequent questions from the book, is that how did you, A, carry a second baby with a prolapse like yours to full term? And then B, how did you birth it vaginally? Because didn't the prolapse kind of block the opening? And they're all the things that we had to process throughout the pregnancy. That was my number one fear. Like if the baby is sitting on top and the bladder's blocking the hole or the vaginal wall, how is it going to come out? Do you know what I mean? And I think that it's a big real fear.
Well, that was certainly something that I asked the doctor at the time. Although I was a midwife, I wasn't a researcher at the time, and I suppose I had a mother hat on.
Yes.
And he said that during the second trimester that the whole area would lift up, and he was correct. It did, and I felt a whole lot better.
Isn't that remarkable, right? So that the same thing was said to me, and in that second trimester you feel less symptomatic, and like, wow, if I could only be second trimester pregnant for the rest of my life.
All that time, exactly. And then after the delivery it all started. Yeah.
Yeah. Oh, look. So at what point did you know that helping others in this birth trauma space was your calling?
Okay, I suppose it was when I was teaching nurses, and I was aware that nurses weren't often very aware of these terrible disabilities to women. I was working at a major university as a lecturer. Only at the beginning, it's only 15 or so years ago, and I noticed that they really didn't understand, and I had to do a PhD to stay in that job as a lecturer. So and during my Masters of Education degree, I presented a paper to a whole lot of academics in a huge boardroom on postnatal care and how inadequate it was for women.
Yes.
And a lot of these people weren't midwives, some were, but they were so overwhelmed with this paper that I presented. I thought, okay, and I entitled it, "Congratulations, you're a mother, your life's never going to be the same again." And it really impacted me just giving that and watching their faces and how they realized after it that women don't really get a lot of postnatal care, and often people that have birth damage. And because I'd had birth damage, I was able to integrate that, and because I'd seen a lot of terrible births. So from that point on, I made a distinct decision to try and seek out someone to be a supervisor, to do research, to then give a voice to women.
Okay, because you have that lived experience of not having a voice and not having that support, right?
Exactly. I had I had no voice, and I used to have to go to work as a nurse, and I couldn't explain to nursing staff. Often I did casual shifts that I couldn't lift. I remember I did mention to one particular male supervisor that I couldn't lift because I had prolapses, and he made fun of me, and I burst into tears. And I remember thinking, this has got to change. So I started talking to doctors, and I was surprised that there were some really lovely doctors out there. I was underwhelmed by others.
Yes, of course.
But on the whole, I think the healthcare team really does try to work together and give good outcomes. And it's a very stressful environment. And having been a trauma nurse, I knew that.
Yes.
I found when I first started, I finished my master's and I was still teaching. And then I went back into the clinical environment at a big major hospital, working in all areas. And I started my PhD with a professor who was well known for working with birth injuries. And it strangely appeared that there wasn't too many of these people around, which I was. And this person worked with imaging and ultrasound. And there was another person in America that worked with MRI. So I was strangely surprised.
Yeah, it's few and far between, considering that we're talking about statistics of 1 in 2 women living with pelvic organ prolapse. And we have, here we go, 2 professors, 1 in Australia and 1 in America. It's a bit unreal, isn't it?
It was very, very surreal. The rest of them didn't seem to know. The one I worked with was excellent. And I thank him greatly because he showed me imaging. He explained the history of it.
Yes.
I understand. And then I read articles, some of his, some of others, of men that had looked at this in back in the 1890s.
Wow.
Without imaging. A guy called Robert Dickinson. He discovered a muscle called the levator ani muscle back in the 1890s, and then there was a couple in the early 20th century up until the 1950s, and then the medical profession forgot. They forgot
about it.
They thought it was interesting research, but it wasn't until this professor showed me in the early 20th century and the one in America, or their research on imaging, that they proved these other guys were correct. And this muscle that was torn off the pubic bone during delivery, that was shown back by Robert Dickinson in 1890s, was an actual fact. And that's why women had prolapses for thousands of years.
And had to use pessaries such as pomegranates and wool and all of these, things that I've learned about.
Terrible things.
Yeah.
And the beauty of this professor that I worked with, he was always thinking outside the square, a bit like working with Victor Chang.
Yes.
And I believe he wanted to change. He wants to change things. He wants people to look at the fact that this does not have to happen to everybody.
Yes.
And that he showed that forceps were a really big issue. And having seen multiple forceps during my time as a midwife, and most midwives don't like forceps, they really don't at all.
Okay.
Especially those Keelans that rotate the baby and that rips the levator ani. Yeah, exactly. That was me. That was me also.
When babies are posterior and they're turning them.
That's right.
Wouldn't it be amazing? Oh, sorry, Liz, you go.
No, keep going. That's fine.
I was going to say, wouldn't it be amazing if somehow there could be some type of imaging done just as you're going into labor to see if the baby's posterior or not? Now, I was told by another midwife that midwives should know if a baby's posterior. But how can they know if it's in the canal posterior? Like, how do you know? I don't know.
That. you can palpate it, and you always, having worked extensively in antenatal clinics, you palpate it and you can feel it's posterior. There's a discussion out there. At one stage back in, it's about 20, 30 years ago, people did some form of imaging to see if they were posterior, and I actually worked in was Crown Street actually, which isn't there anymore.
I was born there.
Yeah, well, I had to do 3 months there during my general training. So yes, a very well-known hospital with lots of really good research. And they used to do imaging, and then they would send the person to a cesarean section.
Yeah, and I think
And I wondered, you are correct, why we cannot do that now.
women listening now who have not had a baby or had a baby and no issues wouldn't quite understand, and they couldn't understand that childbirth is so political. And you've got these two camps, and I talk about it in the book, the obstetric camp and the natural birth advocate camp. Both have really strong standpoints, but I do feel disappointingly that they do try and convince the other that theirs is better, that their method is
correct.
Better.
And you know what, Steph, during my PhD, I was so irritated by that, and I have been constantly irritated by that as a midwife.
Yes.
Because I'm a trauma nurse. I want to work with a good team. I don't like that at all. So I went back into the history, and I found out that the natural birthing method that was started in the 1920s and 30s was started by a man in Britain, right, who was, I don't know whether you know this, who was post-war his name was Reed, Dr. Reed, Dick Reed, and they called it the Dick Reed method. And he was an obstetrician who was working for the government to lessen costs after the war, World War One. Because they did, and the same in Russia, they did hypnotherapy with women because they couldn't afford to give women general anesthetics, any anesthetics. And so the natural birthing method was started by men and health reformers. And somehow along the line, women picked it up in the 1970s, right, and said, we have our own bodies. But they forgot to look at the fact that, yes, we have our own bodies, but everybody has a different body and a different baby.
And a different way to birth, different vagina, different hips structure. Yes.
Absolutely.
Oh my gosh.
So I think natural birthers would be shocked to know that natural birthing was started in the 20th century by a male obstetrician. Absolutely.
I had no idea, Liz. I had no idea that happened. I've only, kind of watched Birth Wars on SBS when you've got professors and heads of midwifery.
I know.
Not loving each other. And as a mum, so as an advocate for mums, my one wish is that they could just use their amazing skill and love of midwifery and caring for women with a little bit of, hey, but this could happen in the medical field, and work together. That's
why my benchmark is Victor Chang always, because that's what Victor Chang and his team at St. Vincent's did. We always worked together, and then we weren't perfect and we had difficult times, but we worked together to get good outcomes. So the nursing staff, the physiotherapy staff, the doctors, the people on the machines, the tech staff, we all worked together, and he is my benchmark. And I came into obstetrics and maternity hoping for that to occur, and I still want that to occur. So I will always advocate for teamwork.
Having that multidisciplinary team. And I think for women who are either pregnant or becoming pregnant, they just need to do a bit more research. Just do a little bit more searching, ladies, because once you kind of see it for what it is, I think that's the only way you can make an informed decision. I read a lot of pregnancy and birthing books now, more so even before I was pregnant. And the messaging is very much vaginal birth and natural birth and no pain medication. Like, it's still being heavily told and sold, as I would say, as I got in my childbirth education. And when women are presented only with one method, they think, well, that's it. That's what you do. But ladies, there's another half of the textbook that it's worth reading before making your decision.
I totally agree, Steph, that women should do their research, but I suppose I'm an advocate for all women, and I think that there's a lot of women that have unexpected births, like they fall pregnant quite quickly, like I did.
Yes.
And coming from my perspective, although I was, I wasn't young, I was in my late 20s, I still hadn't expected to fall pregnant that quickly. And my husband, I did not know my husband as well as maybe some people might know for 5 years.
Yes.
And yeah, it all of a sudden I was a career person 1 minute, and the next minute I was pregnant.
So the timing,
the timing, but also the fact is, if I was a poorer person and I'd fallen pregnant, having worked in community as a child and family nurse, and I was 16, what does a 16-year-old know?
Exactly.
Nothing.
Yeah.
And so I think the reason I've started a business recently on health literacy is to help all people, because I think all people need to be given access to this information so that they can make informed decisions. And this is underpinned by World Health Organization strategies of health literacy. So a 16-year-old person who falls pregnant, whatever area, state, country, should know as much as a 35, 40-year-old who is a health professional, not just a health system for rich people, if you like, or private people.
I love that. And it's funny that you said that, because even when you said at 35, when I first fell pregnant, even though I read all the books that I thought that I needed to read, I still was very uneducated, even though I'm an educated woman. So I see your point that it's actually not the onus of the pregnant woman. The onus should be on the people supporting them to present this information in a non-biased way, right? Okay.
That's my modus operandi, to go into workplaces, to speak to people like you and say that we as health professionals need to help with health literacy. We need to direct and show so that then people can make informed decisions. Because how can you make informed decisions if you don't have correct information?
Or any information?
So the one thing I just want to make a point about here is something that you may not be on your list of questions, is men. I'm not sure whether you were going to bring that up, but I also, during my PhD, I interviewed men.
Yes.
And the shock of all the things that happened to their partners was the fact that they had no health literacy. Men felt an encumbrance in labour ward. They felt an encumbrance afterwards. And then every time they opened their mouth, they were fearful that they might have been named a misogynist.
Or say the wrong thing, do the wrong thing.
Or say the wrong thing. And so when they talked to me, I was lucky enough to, that's one of the reasons the Birth Trauma Association was begun, because of these very brave women and men that I spoke to. So I was very lucky to talk to these men. They were really very caring of their partners.
Yes.
And it was, that their partners that had severe injury, but they were in the dark. They didn't understand what a prolapse was. Why do we expect men to be health literate?
Yeah,
if we haven't told them? We asked them to come into labour ward. We asked them to watch things that most health professionals struggle with also. And then we say, go home and have a good life.
And support your person.
And support your person. And they all said to me, I'm so glad I'm speaking to you. I have looked on the internet. I have spoken to other men. I have asked health professionals, and no one wants to tell me. It's silence. There is no health literacy for us. Yeah. We are an unidentified population. And, I will fight for these men, and I will, because that's when you get marriage breakdown, because then the husband thinks, what is going on here? I failed. The wife thinks you're just a misogynist. You let me down, and nobody's speaking. So I don't know whether that's helping you, but I'm very passionate about this.
Yeah, and I do want to follow up on that, because I know that I really wanted to unpack, because you have done so much work and so much time and passion into researching birth trauma in particular. And I know the Australian Birth Trauma Association was really the birth of your research, and those 40 women and 7 men that you've mentioned who were brave enough to tell their story in the first place. Did you see any common connections between the births and the injuries from those people that you spoke to?
What do you mean common connections?
So
rephrase
that. So I'll ask in a different way. So were there forceps used in those 40 births?
Yes.
Okay.
Yes, a high proportion of forceps used in those 40 births, high proportion.
Okay.
Yes, it's published at Sydney University Library, and there's international papers on this with huge citations on my writing.
Okay.
And a lot of people now are looking at it. When I first did it, because it was mixed methods with an emphasis on qualitative, some of the medical profession, the doctors, were not happy to read it because they're quantitative and they only wanted to look at figures.
Black and white.
But black and white. But we now know in the 21st century that qualitative and interviews are the way forward. We need to find out what people are thinking. We need to find out why things happened, what went wrong, how it went wrong. And these people were so brave, and that's what they did. And so I'm so very thankful. And that was the genesis of the Australasian Birth Trauma Association and the genesis now of my business to do health literacy. But yes, it didn't go always that well for those people. That's why they are so brave, because some of their outcomes weren't very good. But I must point out that the research showed that the people that actually turned up together, the husband and wife, to talk to the urogynecologist, showed that their sex life was much better, and their trauma, which was a finding of my PhD, the PTSD that came from the injuries, was decreased. And when they went to talk to this professor that was part of the team, he explained all this and he unpacked all of this. And one particular couple said that finally somebody answered our questions.
Awesome.
And my wife, the husband said, my wife's PTSD decreased, and our sex life, despite the injuries, has improved, and our communication has improved.
Wow, that is so impactful. I just want to sit with that for a second, because that's huge. That can,
absolutely huge.
Obviously living,
and that's called health literacy.
Okay, that's what. Yeah, right. Having
so that professor was using health literacy, which is what I want to carry the torch.
Yes.
And take that forward, because that was his passion, health literacy, although he wouldn't have called it that.
Okay. Yeah, right. Doing wonderful things and not even really knowing, but potentially. I, having had, obviously my partner's lived through this too. My husband's gone through this traumatic birth and the injuries as well. And I think that's another question is, well, how did you go and have a second baby? Not only how did you carry the baby, how did you birth the baby, but how do you have sex with prolapse? Do you mind if we get into the nitty-gritty of sex and prolapse? Because a lot of women living with pelvic organ prolapse, their sex life, and like I have said, has never been the same. And I was chatting with a lady yesterday who said, she was a midwife, and she said, when they cut an episiotomy, they've only just worked out that when they cut the episiotomy, they cut some nerves to your clitoris. And so therefore, your sex life can actually never be the same. And I was like, what? Really? Oh my God. I never knew that. I thought it was up there and they cut down there. And she said, no, because the research that came out a few years ago shows that the shape of the clitoris and the muscles are much bigger than what they ever thought. So we're constantly learning about our own anatomy every day, right?
Right. Yes. That I'm not au fait with that. It sounds very interesting. I know about the clitoris, but I do know from having worked in labour wards and having seen very violent births that I've seen clitoral tears.
Yes.
In one particular facility, I seem to see them, and often it was due to women in certain positions.
Okay.
Standing positions.
Right.
It doesn't necessarily everybody's saying that everyone's standing, but yes, I saw a lot of clitoral tears. That research is certainly very interesting. Yeah, that is very worrying. Because I'm having worked with female genital mutilation at one particular hospital with women that were delivering. I'm very au fait with clitoral, because the clitoris is removed. So,
yes.
And most of these women from overseas will say that, they don't know what an orgasm is. So,
because they've never had it. It's like that female circumcision, isn't it? Well, that's what they call
That's
it. But
right.
we know it's not.
Yeah, well, it's banned in Australia. Yeah, but yeah, how do you have sex with a prolapse? Well, once again, health literacy, and trying to understand and trying to explain it to your partner. And that's why I was using the example of that one couple who, after speaking to a well-informed health professional, the urogynecologist, were then able to go home and work it out themselves. And their sex life wasn't exactly the same as what it used to be. And there's a lot of people that say, well, I wish we could go back. Well, we can't go back.
You can still have intimacy in different ways. So even if you have pelvic organ prolapse, you and your partner can find intimacy in another way.
Yes, you can. But I think the big hurdle is health literacy. So if you've got no idea of what you're just a person that works in retail or works in high energy economic forums, you've never heard of a prolapse. I mean, I have worked in private hospitals, and I remember trying to explain what a midwife was. A lot of them didn't even know what a midwife was. They're high energy people that work in CEOs in companies. We had big discussions. So if you're one of those people, or you just don't have any information, you need to be well informed. I'm not saying it's going to be easy. I'm not saying that at all. Without I don't know, you want to go into the nitty gritty. When you use that word nitty gritty, what do you want?
I think for our listeners, and
lost you.
Oh, right.
Oh, yeah.
I think for our listeners, potentially, so how would you even start the conversation with your loved one about your prolapse and how it's affecting your sex life? Because
good question. Impossible. It's impossible. And that's what the research is showing. And that when I interviewed my 40 women, up to it's probably about 50% of them asked me to speak to their partner.
Yeah. Wow.
They begged me to speak to their partner as they broke down. These were 2 years of interviews of women that were so distressed that they felt like they kept on saying to me, there was this constant theme, I never imagined there would be this much of marital disharmony. And even trying to unpack that, I'd say, what does that mean and where is that coming from? It was always coming from sex. And the people that didn't speak about it, they just couldn't speak about it. But so that pushed me forward to then speak to their partners and find out what was happening. So it's impossible, because the man thinks that the woman doesn't love her anymore, and the woman feels, well, rejection, definitely, and the woman feels that she's not lovable anymore. She's dehumanized. Her body has become a bloated mess.
It's funny you say that, because there was women who live with pelvic organ prolapse can often describe that the organs in the morning are sitting okay because of gravity of lying down the night before. But as the day progresses and as the organs descend down the vaginal canal, generally, if you have younger children at home, the only opportunity you have to be intimate is when they go to bed around 7 or 8 o'clock at night. So when your partner comes at you to become intimate, that's the worst time of the day. That's the most symptomatic. That's when you just need to be laying horizontal for 12 hours to get it back. So it's probably one thing I've had to work through, even with my own husband, is to try and find the words to communicate that to him in a non-rejection way. But quite often you're so much in pain, or you're so tired, you're just like, no, or you make an excuse, or that whole, I've got a headache type rubbish. But also women who I've, obviously spoken to within our circle say that it's just too hard. They can feel things like their stool at the back passage. So when the penis penetrates, they rub against each other. And the man might not be able to feel that, but the woman can. Oh my God. Who would want that? You need to find a way to not do that. That is an
amazing description, Steph, and you are so brave in actually saying that description. I had different people, but not many, saying similar things. But that's exactly, it's almost impossible to explain that to your partner. But it is possible for someone like me or even you, in the work that you're doing, and urogynecologists, to explain that to a couple.
Yes.
What you actually just said then, wouldn't that be wonderful if you were sitting as the consultant with the family, which is the job that I do. That's one of my hats as a consultant, and I'm hoping to put that out more and more.
Yes.
And you get much better results, because as I use that couple, they felt that their sex life was a lot better. Now, I don't know whether that urogynecologist used exactly those the way you put that. That would really bring the couple together. The father, the husband, would say, oh my goodness, that's terrible.
Yes, I think anyone would. I think anyone. And so I think from the women I've spoken to very privately, obviously they say, well, sometimes if I know I want to give something to my partner, I won't have a massive meal, because then I don't feel the backup of stool, and I'm not as, I go and try and empty my bowel before going into the bedroom, which is so unromantic and non.
It is. And you have highlighted an issue that was really difficult for me to ask women in the PhD. They would not answer that question. Now you're going forward with that, because impacted bowels and prolapse are definite. They go hand in hand, and it's too embarrassing. But once again, someone like yourself and me and another health professional, we can open this conversation and make them literate.
Yes, because quite often
and then happy.
Yeah, and it's like that old saying that I can tell my daughter to do something 10 times. Please pick up your toys. Please pick up your toys. Da, 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 da. And they just hear mum's voice. But the minute the teacher jumps on online learning and says, Elsie, you need to read your book, she's like, oh, she listens. And I think it's the same with a partner. If it's coming from an external source and not your wife or not your partner.
Exactly.
I think the messaging, it can sink in a little bit better when it's someone from that stance.
Men are crying out for that because they feel an encumbrance.
Okay.
And women are asking for help too. Women are wanting their partners to understand.
Yes.
But women can't do that. You can't expect a woman to do that. There needs to be a third person, I believe.
I love that. Yes. I think we've just we've stumbled across something. And I hope that is helpful for women who can't start the conversation with their partner to say that your penis rubs on my poo and I don't like it. They can just say, listen to this podcast, because that's me. Just this is us.
I think we have between us, the innovation of what you've just said has really, that will impact a lot of people. Hopefully this podcast.
I hope. That's my hope, and I think that gets us on to our last part is, how do we better support women? You're doing an amazing job. I'm trying really hard. There's a lot, I think the inertia of talking about prolapse and the taboo and shame is slowly dropping. And I think we're getting better at it, but how can us women better support women when it comes to pelvic health? More so, I know what we're doing. I'm talking about our listeners. What can our listeners be doing to better support themselves and other women in pelvic health?
This is a question on exercises, is it? On Kegels and things?
No,
I'm not sure where you're going.
How do we have the conversations even with our trusted circle? So how can we, so for example, you and I can talk very openly about this, but once upon a time, I couldn't talk to my own sister about it until I wrote a book about it, because I didn't have the words to say. So, like I know in a circle of mothers groups, there's probably 2 of them that have a prolapse but can't talk about it. As someone,
how do we allow them to talk?
Yes. How do we help women in being able to say, hey, I've got this thing. I think I don't know what it is, in my vagina. I don't know. You know what I mean? I think our mothers groups are the way to move forward in our circle of friends and women.
I think yes, the mothers groups are always very powerful. Mothers groups are very powerful, but once again, it needs to come from health professionals. It needs to be a fact sheet. It needs to be something that you pick up in the antenatal classes or the postnatal. I'd like to see postnatal classes.
Same.
I know that governments may not be very happy, and especially not at the moment, but I'd like to see maybe dialogues in community centres. I think that's the place where you need it. Having worked in community with mothers and babies, I think, and everyone goes to the baby health centre to have their baby weighed.
Yeah, that's right.
And I think that, well, the one centre I worked in, we used to have different information drops, if you like. So I think that is a facility that could open up this conversation, and then mums can go and have a cup of coffee, and then they can say, well, you know what the nurse was saying this morning, I've got that. That's how it needs to always come from the health professional. You can't expect mothers are amazing people.
Yeah, I hear you. I love that. And because I remember going, like every Friday we went to the clinic, we all weighed the babies, and I think we did that for 6 weeks, and then every Friday there was a session or something like teething,
there you go.
Breastfeeding. One of them could be definitely about prolapse, because even if you don't have prolapse at birth through forceps and damage, you can most certainly have prolapse stage 1, 2, or whatever after you finish breastfeeding and you don't even know it.
Exactly. And then the idea is to refer them for imaging to see what the treatment options are, because they're the issues, and to see what help they can get and get good help. And have a pool of good resources, not bad resources, and not referred to technicians that don't really understand what they're doing.
Yeah, that happens a lot, and women get frustrated by that. Would you consider, Liz, for pelvic organ prolapse to be a disability? Here's a can of worms.
I don't think it's a can of worms. I think it's a very, but it's, I hear what you're saying. I think most women don't like to see themselves as having a disability because it's uncomfortable. You want to be a sexual being. You want to be normal. You don't want the thought of something protruding from your vagina. But yes, it is a disability. You can't go to rock concerts and stand up and dance. You can't run. You can't
pick up your kids.
Walk. You can't pick up your kids. You can't work as an intensive care nurse.
Yeah, a lot of women wee themselves.
You have to change your job.
Yes, you lose your career. And so it's so
it's a disability.
Yeah, and I think, and I have talked about this on other episodes, it obviously also depends on the grade and type. A lot of women hate the grading because one day you feel like you could be a grade 2 or 3, and the next day you feel like you're a 4. Like I think it's very fluid. It's not quite linear, but anything by definition that stops you from living your normal life, and I hate using the word normal because I don't ever want to offend the community of people with disabilities either, as if it's a versus thing. That's just the terminology I think we've been brought up with, and that we know. Please tell me if anyone's listening and there's a better way to say it, tell me, and I'm all for it. But I think that women, anything that they say by definition stops you from doing your normal activities for longer than 6 months is by definition classed as a disability here in Australia.
Absolutely. And prolapses are long-term issues unless you get miraculous surgery. And those surgeries are few and far between.
And for those women who are perhaps a stage 1 and can't feel it, or a stage 2 and can have intensive physiotherapy or regular physiotherapy to improve it to a number 1, and then their life does carry on as if they didn't have the prolapse. So that's very different. We're talking about a disability for women in that grade 3, 4 area where they can no longer continue their career, can't walk to the letterbox without pain, can't pick up their children, pooing and weeing.
Absolutely. It's a travesty, and it needs to be labelled as a disability.
And it's funny because
a taboo.
I put the question out there even within our own community, because I also don't want women to feel like they're labelled with anything if they don't want to. But I think quite a few women said, well, if it meant that I could access better support for living with this, then I'm okay
Yes.
with that. I'm not against being
Exactly.
disabled. I don't care if people call me disabled, but because they can't see it, I think I'll be judged poorly by it. So, and I've had
Yes.
those personal feelings creating that short film about called My Invisible Disability. I thought, ooh, as a child growing up, I saw disability as somebody in a wheelchair, because that's the symbol used on the car parking, or someone who has a limb missing, or they're deaf or blind, or a chromosomal thing, or from a car accident. I never saw it as something that happens in a birth injury that you can't see. So I think, am I disabled? I don't know. I don't care if that's what it is, but you're just constantly questioning yourself, because you think, well, other people will say, well, you're not, because
You're constantly hiding it. I think
Yeah.
you're constantly
You look
trying
normal.
to be a beautiful person, and you don't feel beautiful inside.
Oh no. No. Do you know one thing that really irks me, Liz? Here it is. On social media, I mean, there's obviously a lot of things, but when I read posts saying you are not broken, it's all in your mind, and usually it's coming from like a physiotherapy, natural birth advocate style of company or person, saying that, you know, you can heal your prolapse and you just got to change your mindset. I think, come and live an hour in my body and tell me if you feel broken, because I feel very broken every day.
Exactly right. Exactly right.
I'm trying
And you
immensely.
feel like you don't want the facade anymore.
No, and I'm trying immensely to be positive and find workarounds and do all these amazing tips and tricks and share them with the world. But at the end of the day, I still feel really broken. I still can't pick up my son when he's crying. That's shit. So to read things like that, I get really upset, because it's silencing us again, this unseen and unheard community, because it's just too hard to take it on, you know.
Exactly right. And there needs to be more money and research put into this, so that there can be better outcomes and better treatment options.
Yes.
Pessaries are, to me, very difficult.
I can't wear them. With avulsions, I don't know many
with
women.
avulsions, bilateral avulsions, very unlikely that, and I know you'll hear people, but because I'm also an expert with UK Birth Trauma Association, who have been the reason Birth Trauma Australia started. They started in 2003.
Yes.
And Canada started in 1999. I'm sent women who are very distressed, and I've recently been speaking to a woman in Scotland who tried every pessary under the sun with a bilateral avulsion, and her marriage broke up. There was domestic violence involved. It was you see, these are all the hidden issues.
Horrific.
And so, I mean, I will continually follow up this woman, and so will UK Birth Trauma, and we'll try and get her much more help. But she's a very, very brave woman, but pessaries are not her answer.
No.
She definitely needs, and I'll venture into this, some form of surgery. And because I'm in connection with IUGA and ICS, which is the International Urogynecology Association and International Continence Association, there is a bank of really good doctors. Now, this surgery may not be absolutely perfect, but there needs to be, in some of these situations, more than you may think, a form of surgery that will get people some quality of life back. And now I'm speaking like Victor Chang again, because Victor Chang would always say that we are always looking at quality of life, Liz.
Something better.
And okay, cardiac operations may not have lasted as well for some, but they got quality of life. And I thank him so much for that, because I'm speaking to you now, all these years later, and saying that that woman in Scotland, we have found someone for her. Wonderful. And she will get some form of surgery, but that's thousands of miles away, and they're speaking to me in Australia.
That's wonderful.
There's very few people, but there's more of us, and you're one of them, who can help these people. So
I hope that's why I do what I do. So there's obviously two-pronged approaches, that I want to be able to help others, and with education and information and support. But then two, it actually keeps me going. I could no longer continue my career in 20 years of education because I can't stand or walk without being in pain for too long. And as a teacher, that's just not practical. Although, funny enough, I could have done it now while in lockdown because everyone's online. But
But you already are a teacher. You are teaching and you are doing health literacy. That's what you're doing now. You've just changed the area that you're doing.
Topics. Yeah.
So
thanks, Liz.
I think we need to, as mothers, often we use all these different skills just in different ways.
That's so true. That is so true.
But you're not a mother anymore. You're an educationist. That's how I see you.
That's lovely. That's really, and I want to continue doing what I do and making sure that by the time it comes around for Elsie to have, her babies, or actually, you know what? That's silly. From now, she's 5. I now want to start educating her about her anatomy. So knowing that her vulva is different from her vagina and they do different things, and knowing that her pelvic floor muscles are really important to look after as a young woman and as a teenager before she gets to birth. So things like looking at chronic constipation or coughing or diet and exercise are all part of the puzzle, that childbirth isn't the only thing that can damage your pelvic floor, that it's encompassing of a healthy lifestyle from very young. And I think by teaching her those skills now, I can only hope it's going to lead to better outcomes for her. You can't avoid prolapse. I understand that with, menopause and hormonal changes and a whole lot of other aspects. But I think I knew nothing. I didn't even know what my pelvic floor was. I heard about Kegels and pulling up. But
I think the thing about menopause, I think, is, yes, it does increase the prolapse, but the prolapse will be there in the first place. And I think that was what I learned from my research, that a lot of women I agree with you. I think, whatever way children are taught in anatomy and physiology, biology, that's important to their lifestyle: eating, drinking, ensuring bowel habits are correct. I agree. But I think there's a few myths out there about, like, prolapses only occur to menopausal women.
That's the old school thought, isn't it? That you only get it after you've gone through menopause.
They only occur to fat people. They only occur with and there's a whole list of things there. It's old hat stuff. Really, I interviewed 21-year-olds that had severe prolapses. And women will try and listen to all this. They're forced to listen to this stuff. It's wrong teaching and it's wrong. Okay, so yes, menopause does exacerbate a hidden prolapse, and I think urogynecologists will, hidden when I say occult or not as severe, it will exacerbate it because the hormones. But not to be, a 21-year-old doesn't need to hear you're too fat or you're this.
You've caused it. Yeah. Thank you for pointing that out, because you're constantly learning along the way. There's so much. It's so complex, isn't it? Our bodies are so complex.
Yes. And I think for centuries, and that's why I'm so interested in the history of all this, for centuries, women have been putting up with this, and it really wasn't until these two great professors, the one in Australia and the one in America, showed on imaging what the men, and they were mainly men, they weren't women, in the 20th century and late 19th century had discovered the levator ani. And you will speak to hospitals today and you will find there are no evidence-based guidelines on levator ani. I'm giving a presentation to some people very soon on complementary medicine who want to know more about this stuff. So we need to put that to help their patients, because their patients are coming to them and saying, I've got this strange injury, and they want to know how to explain it to them. So I think the more we give once again, health literacy. And we thank those two professors for putting that research out there, and we need to run with that, because women have suffered this stuff for too long.
Yeah, it's enough is enough, isn't it? Really. And it's wonderful that, you know, I'm been talking to women on the podcast that technology is coming a long way, and pessaries will change. We will finally see a change in the shape and form that they've done. But wouldn't it be better to try and work before the problem rather than the solution, working out what happens?
You mean prevention?
Prevention. Yeah, rather than the solution.
Absolutely. Yes, there is more work with pessaries, and our physio friends will definitely say that for some women that's a really good answer. But yes, wouldn't it be nice that we could decrease the use of forceps? I'm not saying that forceps save babies' lives. They saved my son's life.
Yeah.
But forceps, and there's nothing. And my colleague in Canada who runs an organisation called Choosing Caesarean Section, there are some women that really do need to have caesarean sections. And she's worked beautifully with Britain, and she's changed guidelines to make it possible for people to choose caesarean sections. And in this day and age, caesarean sections are very safe. In developed countries, of course we need to look at the side effects of all things, but I'm sure a lot of people would prefer a caesarean section than a lifetime of prolapses and fecal incompetence.
Yeah, that's right.
Or incontinence, and
absolutely. Anyone who, in hindsight's a wonderful thing, and I think I wish I would have even had an option. There was never an option for me. The caesarean section was not even allowed to be talked about in my natural birthing.
Exactly right. And that's public health in Australia, whereas in Britain, this woman has changed the NICE guidelines. It doesn't always happen, but it's been changed, the national guidelines, that is, to get women choices, give women choices.
Yeah, that's right. So lastly, I just want to ask Liz, what would be your big hope for this picture in, you know, birth trauma and pelvic health for women?
Health literacy, definite health literacy underpinned by World Health Organization, whether it's discussing like we were about really fragile situations about sexual issues, like you pointed out so vividly, health professionals having more education to impart and give people access to care and problem solving. Health literacy.
Wonderful. Now, if someone's listening today and would like to find out more about what you're doing in your business now, where could they find you? What's the best way to contact you?
Okay, it's birth trauma consultancy. Just Google it, birth trauma consultancy, Elizabeth Skinner. You can just Google it, and there's a whole page there. A web page, and I'm there to do work with health professionals, and with mums and dads, and dads by themselves or mums
or partners. So that's for partners too, right? We're not talking about just definitely families. It's all family inclusive. Beautiful. Okay. Yeah. And I think we'll add your link to the show notes down the bottom so people can find you directly, but it's just nice to know how they can work with you and what support you can give. And I would definitely recommend anyone to go and check out your website, and you're doing an amazing job. Thank you so much for all you do in this birth trauma space, and we look forward to seeing what comes next.
Yes, and working together. Fantastic. And thank you for all the brave and amazing work that you do with your site. And it really is brave. So
thank you, Liz. It's been great to talk to you. Thanks so much.
Thank you.
What an episode, jam-packed full of goodness, right? I'm sure that with women like Liz around, we will be able to be and see the change that we need for our future girls. Now, I know last week we talked about asking you to head over to iTunes and leave a review, and thankfully one of our beautiful listeners reached out and said that they really weren't sure how to do it exactly. So we've created a really short clip to help guide you through this process because we value your time and your energy and we don't want to make it hard. So if you're part of the Brave Mamahood already, this would have been sent to you via email. And if you are not yet part of the community, you can sign up through the website, or you can just send us a message and we'll email it straight to you without having to sign up to the Brave Mamahood. All right, really exciting. Next week, we are interviewing Sarah Prime. Now, we talked to her in a 2-part series here. Next week's interview is her pre-surgery chat about prolapse and then what her expectations are of the surgery she's about to have. And then our follow-up interview is going through what her surgery was like and where she's up to now. So until then, tune in and bye for now.
Mama.